Hello again. Today we're going to be dealing with the emergency drugs and anesthesia, which is a topic a lot of people have asked for. We're going to be covering why bother to draw them up, what to draw up, how to draw them up, some of the modifications for low and middle income countries, and then finally some of the special drugs such as Dantrolene and Intralipid. So why bother drawing emergency drugs up? Why not just call for the drugs as they're needed, which would save potentially a whole lot of resources and time when you're preparing? Well, the first is that sometimes speed really matters. So if you're dealing with a peri-arrest situation, sometimes a minute or two of your time can be absolutely crucial for patient outcomes. So peri-arrest bradycardias or precipitous hypertension, maybe it's better that these drugs are available, so all you need to do is reach across for them and give them. So when speed counts, have the drug drawn up. This might not apply to something like tranexamic acid, which is a drug that needs to be given in a few minutes, but there's some like atropine that need to be given quickly. Secondly, do you have help in the room? So you can't leave your patient to draw up drugs when there's an emergency ongoing. So if I have a registrar in the room with me, then I know one of us can look after the patient and one of us can draw the drugs up. But if you're the solo anaesthetist in the rural hospital, it's worth taking the time before the event so you don't get caught out. And think of a laryngospasm scenario. You've got a patient whose airway is obstructed. Now you need to try and manage the airway, and you need to draw up something like succinylcholine. You can't do it if you're the only pair of hands in the room. So in those circumstances, low threshold to draw up emergency drugs. And finally, there's a cognitive load. It's one more thing to think about during an emergency if you haven't drawn up the drugs. You're suddenly going to have to remember what the drug dose is, how to dilute it. It's not just going to be there for you. And so then your attention is distracted towards the drug instead of managing the patient and just saying to someone, please give 1 or 2 mils of that drug. Are there risks to drawing up emergency drugs? Well, there are always benefits and risks. One of the most common things that happens is we can give the wrong drug. There was a survey done in New Zealand where 26% of anaesthetists said they've given one of the emergency drugs they're drawn up by accident. It's a real risk, and it's why when you draw up these drugs that you need to label them very, very clearly. Often we all have little specific ways that we mark these syringes, and you have to put them away from the drugs you're planning on giving routinely. So you need to store them intelligently, and this is a very real risk, and many of us have stories of when we've been caught out. Secondly, they get infected or contaminated, so if you draw up these drugs and don't use them, there's a risk that they can then harbor infection. Most drugs we don't keep for more than 24 hours, and some drugs like propofol we wouldn't keep for more than 6 hours. So this is a thing that needs to be managed, and it's why many of us will date and time write those things on the syringe so we know exactly when they were drawn up and at what time they were drawn up. And then thirdly, resources are a problem. We may be short of the actual drug or the money to buy the drug or both. So if you're short of succinylcholine, it doesn't make sense to draw up a new amp of succinylcholine for every single case on the off chance that you'll use it. So we make modifications for low-income countries, and that instead of drawing up the drug for every case, we think of a way to make it easy to get access to that drug without wasting the amp every single time that we do a case. So what should we draw up for every case? So which emergency drugs should you draw up? Well, if you look at the guidelines, there's actually quite a lot of variation around what is suggested. But in general, you'll need drugs that support the blood pressure. And when we talk about these drugs, usually you're choosing between adrenaline and then a drug like ephedrine and a drug like phenylephrine. There are others, but these are the ones that we commonly have available. I've put in bold adrenaline because adrenaline may also be used to treat something like anaphylaxis in addition to blood pressure. Drugs that affect heart rate, usually that combat bradycardias, and these would be your anticholinergics, or more correctly your antimuscarinics, and the common two are atropine and glycopyrrolate. Of those two, we tend to use atropine because it's faster acting. but either actually will work. Muscle relaxants, here we need a fast-acting muscle relaxant, which in our setting is pretty much just succinylcholine. Some people would include rocuronium here, but those people must have access to Sigamadex, so it needs to be something that is short-acting, and rocuronium is only short-acting if you have the reversal agent available. And then finally, many guidelines suggest that you have an induction agent drawn up, or at least immediately available. And here there's a number of options: propofol, etomidate, ketamine, and if you've got access to a thiopentone, although that's increasingly more unavailable. So those are the 4 categories of drugs one should consider. And in general, you should either draw up or have immediately available one from each category. So this is what the Royal College of Anaesthetists suggest. And you'll see there they've got the common emergency drugs and then the other emergency drugs. You'll notice that the red drug succinylcholine is for your rapidly acting muscle relaxant. Then we've got 2 in green that treat bradycardia, and then the purple drugs which do blood pressure. So they haven't included in this list the induction agents, but they do elsewhere. And then the other emergency drugs they think should be available are Intralipid and Dantrolene, and I have got a slide on each of those at the end of this presentation. If you look at the South African suggestions, this is taken from the ESMOE guidelines. And remember that I'm going to go through quite a few drugs today. You're allowed to cheat. So use handouts, print these things out, laminate them, put them in the walls in theatre. And ESMOE stands for the essential steps in the management of obstetric emergencies. And you'll see they've divided this up into drugs you should draw up for every single case, and then drugs you should have available but not necessarily drawn up. And once again, they've got ephedrine or phenylephrine, so something for pressure. They've got an induction agent, either etomidate or propofol. They've got succinylcholine and atropine, and then they've included oxytocin because we're dealing with cesarean sections as well, which I won't cover today. They've also got have ready but not drawn up a number of other agents, and what I want to just draw your attention to is that they've got adrenaline, which they suggest you should put 1 milligram in a 200 ml bag of normal saline. Now, you're not supposed to draw that up in advance. One of the things that worries me is that phenylephrine is often drawn up in a 200 ml bag as well, and there's a real risk of confusing them. But if you're needing it in an emergency, putting an amp of adrenaline into a 200 ml bag gives you a 5 microgram solution, which is not a bad solution to use as boluses. Then you give 1 to 2 mils of that, and that'll be very effective in treating treatment-resistant hypotension. Another thing that's worth thinking about is, what does the patient in front of you look like? So if you've got a critically ill patient, a very hypotensive, septic, or as you can see in the heading for this article, someone that's bled out, that patient may need a lot more emergency drugs than your standard elective case, or even your standard emergency for a patient that's not overtly ill. So you may need more than what I'm suggesting, and specifically for adrenaline, I don't routinely draw up adrenaline, but if you've got a sick patient, you should draw up both bolus adrenaline and infusions, which I'm going to come to. Also very important is that many of these agents are designed for treating low blood pressure, but you need to understand the mechanism of the low blood pressure before you pick the appropriate drug. So if the blood pressure drops from a spinal anesthetic, vasodilation is likely the cause, and phenylephrine would be the right drug. But if the blood pressure drops in a general anesthetic, there are a variety of possibilities: inotropy, vasodilatation, arrhythmias. There are a number of things. And then the correct agent wouldn't be phenylephrine if you weren't sure what the cause was. So starting with blood pressure support, the most widely known drug would be adrenaline, or the Americans would call it epinephrine. And they often talk about this as being a 1 in 1,000 solution. I think that's hard to remember then with dosing. So a milligram in 1 mil is probably a better way to express it. Remember that adrenaline works through multiple receptors, both alpha and beta, and this causes vascular smooth muscle contraction. It affects the pupils, it affects the intestine, but basically you're going to get an increased heart rate, increased myocardial contractility. Those are both through beta receptors, and vasoconstriction through its alpha receptors. So basically, adrenaline is going to act on every component that contributes to hypotension, except for fluid status. So it's a very good drug when you're not sure what the cause of the hypotension is. It's also a very powerful drug. It doesn't tend to be first line unless we're in a peri-arrest situation. And as a result, I don't routinely draw this up in theatre, but I do have it immediately available. And for sick patients, I have it pre-drawn. Now, there are lots of ways to draw up adrenaline. If you're going to do CPR, you need to give 1 milligram as a bolus dose, and then you can give it undiluted, and you can just draw it up in a 2 ml syringe. 1 ml is 1 milligram, and you can bolus the whole lot. If you're wanting to give smaller boluses, like for treatment-resistant hypotension, you want to give 5 to 10 micrograms per dose, or if you're treating anaphylaxis, 50 to 100 micrograms per dose. And there's 2 ways you can dilute that. You can either do it, as I mentioned before, 1 in 200, where you put a milligram in a 200 ml bag. That'll give you a 5 microgram solution. Or you can put an amp into 10 mls, take 1 ml out of that into a 20 ml syringe and dilute that up to 20. That's also a 5 microgram solution. And I'll tell you what I do in a minute. But the third thing that you may need to do is infusions, and there you generally want to give a 0.1 microgram per minute, microgram per kilogram per minute starting rate, which is about 10 mils an hour of the infusions I'm going to tell you about in a second. Now, you've got all these ways that you can draw up adrenaline, and sometimes it's hard to know which one should you pick. If I'm going to pre-draw it and I'm concerned that I might need to give boluses, I tend to put a milligram in a 10 ml syringe. That gives me 100 micrograms per ml. Then if there's a need for CPR, I can give the whole 10 mls, and that's a milligram. If it's anaphylaxis, I can give 1 ml. And if I want to give those smaller doses, I just take a ml out of that and put it into a 20 ml syringe, and then I can give 1 to 2 mls of that. But really, you can draw up the adrenaline in any of these ways based on what you think that you will need in that particular situation. Coming to infusions, what I suggest you do in the district hospitals is you put 1 milligram and 50 mils in a syringe driver and run that at 10 mils an hour. That'll actually run it at under 0.1 micrograms per kilogram per minute, and then you can just titrate that up. If you've got a 200 ml bag, you can put 4 milligrams in 200. It's the same concentration, and start it at 10 mils an hour, and you can run that through an IVAC. Other ways to give it, if you don't have syringe drivers or IVACs, 4 milligrams and 200 mils you should run through an IVAC, but you can even just put 1 milligram in 1,000 mils and run that freely, just titrate to effect. And that's the sort of unregulated adrenaline infusion when you don't have access to the appropriate. So after adrenaline comes ephedrine. Ephedrine has both alpha and beta effects, and it's more of an indirect acting agent. It has the same effects as adrenaline, but not quite as potent, and it does tend to wear off. So it's a shorter acting, and also after a while the ephedrine stops working. It's not a bad one for a general anesthetic when you don't know the origin of the hypotension. The ampule comes in a 50 milligram ampule, 1 ml, and the dose you want to give is 5 to 10 milligrams intravenously. And what I do then is I take 1 amp and I put it into a 10 ml syringe, so that you have a 5 milligram per ml solution in a 10 ml syringe, and I give 1 to 2 mls of that. And if I've got a slate that incorporates both spinals and general anesthesia for my day, this is a good drug to have drawn up, and I'll use it at some point. It can be used in cesarean sections, it can be used in general anesthesia, and it's a very good one to pick when you don't know the mechanism of the hypotension, because it'll support all those aspects I talked about before. Phenylephrine, this should be used for pure vasodilatory hypotension. The most common indication is an obstetric spinal. There we can expect vasodilatation, and phenylephrine is my go-to drug. So for a cesarean section slate that I'm doing under spinal anesthetic, I always pre-draw my phenylephrine. I put 10 milligrams of phenylephrine into a 200 ml normal saline. That gives you 50 micrograms per ml. And I use this for both bolus dosing, 1 to 2 mils, and I use it for the phenylephrine infusions so that I keep it simple and I don't have different concentrations of phenylephrine floating around in different syringes and infusion pumps. I don't tend to use phenylephrine in general anesthetics because the mechanism of hypotension tends to be more than vasodilation. I would only use it as a bridge. If there was nothing else available, I would still give the phenylephrine before I got hold of either some ephedrine or some adrenaline. And if you're looking to see how these are drawn up in more detail, you can go to on the channel. There's some YouTube shorts. I've gone through the phenylephrine dilution and how to give phenylephrine in the bag as an unregulated infusion. For heart rate support, when you need it, it's urgent. So I always draw up atropine. In my career, which is now depressingly long, I've only used it once, but it saved a life. And it's just a drug that I want available. When you do get those bradycardias that are peri-arrest, this is the drug you need. So I do draw it up. Remember, it inhibits the muscarinic actions of acetylcholine, so it's an anticholinergic. The ampule that we get is a 0.5 milligram ampule. You do get a 0.6. I think you even get a 1 milligram, but our one is 0.5 milligrams. And we want to dilute this to 0.1 milligrams per mil. So what I do is I put 1 amp in a 5 ml syringe. Some people ask that you put 1 milligram in a 10 ml syringe, which is the same dilution. This is in fact what ESMO-E suggests. And the reason for that is that the dose is 20 mics per kilogram, and often you need to give more than 0.5 milligrams. But having 0.5 milligrams available in that dilution helps. It also means if you've got some younger patient, pediatric patients on your slate, you're able to give a smaller dose if you need. So this is a drug I always draw up and pretty much routinely at 0.1 milligram per ml. Succinylcholine comes as 100 milligrams in a 2 ml syringe. When you draw this up, label it clearly. This is one of the common drugs that people have stories about. You know, they reached over to give the oxytocin, and instead of the oxytocin, they gave the succinylcholine. There's always horror stories, and you really want to avoid this happening to you. My succinylcholine 2 ml syringe is colored in on the plunger. There's a lot of black on the syringe to make me double take. But remember, the best way to avoid an accidental drug error is before you give the drug to read the label that you've written on the syringe or the sticker that you've put there. Lots of options for drawing it up. You can put 100 milligrams in 2 mils. That's generally good for adults. You can dilute it in a 5 ml syringe or even a 10 ml syringe. I put in a 10 ml syringe when I've got pediatrics on the go and I might need to give a smaller dose. If I'm doing an adult slate, I put it in a 2 ml syringe. And when we're short of succinylcholine, which is very common nowadays, I don't draw this up anymore. I simply get the syringe and the needle ready and I label it and I leave it empty next to the ampule so that the procedure is much quicker when we get there. But this is purely to save a scarce resource. It's not because of cost, it's because of drug availability in South Africa. And finally, induction agent of those 4 classes. I always have one available. I don't draw it up routinely unless I think there's a high chance that I'll be needing it. And you can choose between propofol, etomidate, and ketamine. Because the indications for this induction agent will be different, I tend to have them available without drawing them up. And just remember that if you've got a hemodynamically unstable patient, propofol is probably not your best option. But you can think through that at the time. Definitely available, but I would advise not drawing it up routinely, partly because of cost and resources, but partly because it's less commonly needed. And then, like I said, we've got some shorts available if you want to go and check how to do things. I've also got how to dilute adrenaline for local anesthetics and local anesthetic doses. Now, modifications in low-income countries and resource variable countries mean that it is acceptable to not draw up the ampule for every single case. But what I would advise is that you put these drugs in a specific area where they are easily available. And if you need to point to someone who is perhaps less skilled, you can say, draw that drug up in that syringe. And you can tell them how to do it. And you can even preload a syringe with 9 ml of normal saline so that when you add the milligram of adrenaline, it will immediately be that 100 mic per ml adrenaline. And you must come up with your own solutions in these areas. Just remember that if you preload syringes with saline, I personally have tried to put a patient to sleep with 20 ml of normal saline that I'd labeled thiopentone. This happens. Fortunately, I waited and I saw nothing happen, so nothing happened to the patient. This is what happens when you label drugs in advance that haven't actually got drug in them yet. They're just the saline. So think of your own solution, but also think of what can go wrong in an emergency. And it is certainly defendable not to have drugs drawn up if the resource is limited. But if you've got the resource, it's definitely safer to have drawn up in advance. And the more junior you are, the more you must draw these drugs up, because you want to reduce that cognitive load. So this is what I do for my slates. I always draw up a vasopressor. If I've got general anesthesia on my slate, I draw up ephedrine. If I'm only doing obstetric spinals, I draw up phenylephrine. And I have adrenaline available, but I don't draw it up unless I've got sick patients on my list. I always have succinylmethonium available. I have a syringe ready. I don't routinely draw it up because we are running out of succinylmethonium on a regular basis. I always draw up my atropine, and I would be prepared not to draw it up if we were short, but we've never run out of atropine, so I draw this up routinely for a slate that I'm doing, and I put 0.5 milligrams in 5 mils. And I always have an induction agent available, but I don't draw it up routinely. Just to mention on some special drugs, because I've been getting questions on this more and more commonly. Dantrolene, should you have it in a district hospital? Remember that Dantrolene is the specific treatment for malignant hypothermia, which is a rare life-threatening genetic condition triggered by certain anesthetic drugs, particularly volatile agents and succinylmethonium in these susceptible individuals. It's a hypermetabolic syndrome, so you see a massive increase in body temperature, muscle rigidity, and classically a very, very high end-tidal carbon dioxide. And the treatment is prompt recognition, removing the offending agent, and then using this drug, Dantrolene. Now, the problem is that to treat it, you need this dose, so 2.5 milligrams per kilogram, which you have to dilute with 60 ml of sterile water per vial. And you need to give basically 9 vials to an adult. That's your initial dose. So that procedure takes a while, and you need to get that all in within 10 minutes of the precipitating event. So that on its own is challenging. You then need to be able to follow that up with more doses, up to a maximum of 10 milligrams per kilogram, which might be 27 more hours, but most people say you need access to another 20 vials. Now, Dantrolene's expensive, and it expires, and malignant hypothermia is a very rare event. Generally, when this condition presents at a district hospital, the patient doesn't survive. But when you're dealing with health economics, supplying every single district hospital in the country with enough Dantrolene, which then expires, is also a difficult scenario. So in general, even in regional and tertiary centers, we tend to keep 9 ampules available, and we have a system where we will collect the other vials from neighboring hospitals should we need it. And I don't think it is possible to keep Dantrolene in every single district hospital in the country, much as I'd like to. I think that it's probably unachievable. So if you're in that district hospital and you want to have some system, make sure you know where your nearest Dantrolene store is. That might be at a regional hospital. If it's out of sight, in terms of it'll take several hours to get the Dantrolene, then you probably need to have a discussion about whether you want to stock this. In most circumstances that I've been involved, the decision ends up being no. But then you need to be aware that if you get a patient with malignant hypothermia, you're not going to be able to treat that patient properly. It's rare enough that this is probably defendable. It is very traumatic to have to deal with one like this, and I know we've had one recently where even though the clinicians were able to diagnose the condition, they were unable to treat it. So it's a difficult scenario to be in, and this is the reality of the circumstances that we work in. The second drug, which has got much of a similar way we need to manage it, is Intralipid. Now, Intralipid is used specifically for the treatment of local anesthetic toxicity, and in particularly for bupivacaine. Now, bupivacaine toxicity leads to arrhythmias, in particular a treatment-resistant ventricular fibrillation, and there's really no treatment for it. It's incredibly difficult to treat unless you have 20% Intralipid. So 20% Intralipid, you give 1.5 mils per kilogram as an initial bolus, and then you can repeat that, and this works. It's a very effective treatment. The problem is the drug's not cheap and has a shelf life of less than 1 year. So in a very well-developed system, what you do is you put these bags in district hospitals, and then as they get near to the expiry date, you send them into regional and tertiary hospitals, and they can use this in TPN. In reality, it's probably too expensive again to put in every district hospital in the country, but if you want to put it in your hospitals because you're doing a large number of regional blocks, particularly nerve blocks, which use high-dose bupivacaine, this is a drug you can consider stocking, and again, it's one of those health economics situations which is difficult to answer. And finally, remember, it's safety first. Label your drugs well. Use consistent dilutions that you know how you've drawn them up. Consider where you store them in theatre so you don't give them accidentally. Develop good habits. And if you're not sure whether or not you need the emergency drug, probably you should draw it up until you're sufficiently confident and comfortable with your anesthesia that you're prepared to do it without the emergency drug available, because you think you can get that emergency drug in your hands very quickly with the help that you have in the situation that you're in. Thank you.